Hello, this is an audio lecture on the portion from Cootie BrickRoad on antivirals and antifungals. So we will discuss the topics and objectives for those chapters, and then I will summarize the first two antibiotic chapters. Viruses are smaller than bacteria most of the time, and they replicate only inside of the cell of their host. And so unlike bacteria, where they can replicate outside of the cell, viruses only replicate inside the cell. They can enter the body through inhalation, that's similar to bacteria, ingestion via the GI tract, that's also similar, transplacentally via mother to infant, and then via the skin or mucous membranes. So that sounds a lot like bacteria. So the big difference there is that they replicate inside the cell. Prominent illnesses that are viruses that you're probably familiar with: smallpox, sore throat known as viral pharyngitis, conjunctivitis of the eye, warts can be a virus, influenza, that's the big one, type A, type B, H1N1, avian, swine flu, those all fall under that influenza category. Respiratory infections, viral respiratory infections, RSV, the respiratory syncytial virus, gastroenteritis, human immunodeficiency virus or AIDS, herpes, and hepatitis are all viral illnesses that you might have heard of. Few viruses can be controlled by drug therapy. Many viruses that we will encounter just kind of have to run their course. Another reason that viral illnesses are difficult to treat is because they replicate themselves many thousands or millions of times before the symptoms will start to appear. And so by that time, it's really hard to treat. Herpes simplex virus 1 is most commonly associated with perioral blisters. So what I'm talking about with herpes simplex 1 is cold sores. Oral herpes or herpes simplex virus 2 is blisters on the genitalia, and we also hear that genital herpes. I'm sure you've seen the Valtrex commercials. VZV is a type of virus that most commonly causes chickenpox in childhood and remains dormant for many years and then reemerges in later adulthood, and so we know this as herpes zoster, and you also may have heard of the term shingles. So herpes zoster is associated with chickenpox and shingles. There are two recognized types of human immunodeficiency virus, type 1 and type 2, HIV-1 and HIV-2. Both can cause or lead to AIDS, but HIV-2 is usually located in Western Africa, with type 1 causing the majority of the HIV cases in the rest of the world. And now, when people are diagnosed with HIV, we've really got the combination drugs down so much that many of them will not go on to develop the AIDS virus. The antiviral drugs will be broken down into non-HIV and HIV. So with the non-HIV antivirals, really they block an enzyme that stimulates synthesis of new viral genomes, and that impairs the replication of the virus. Really what it does is it makes those concentrations in the blood lower to protect the patient's immune system. So if I use Tamiflu, for example, it's not going to cure me per se, but it's going to make the virus less virulent, prevent complications. If I take it within the first 48 hours, it can make the flu less severe and hopefully make it last a shorter duration of time. But Tamiflu, it's really important for patients to understand that if it isn't started within the first 48 hours of symptoms, it is not going to be effective. For the antivirals for non-HIV, we use it for the flu, chronic hepatitis. Some side effects are GI disturbances, fever, easy bruising, anemia, and weakness all go along with some myelosuppression that can occur with these drugs. Crystalluria goes along with kidney issues, so we want to make sure that patients are pushing fluids to prevent that. Jaundice would be a liver side effect, so obviously it's contraindicated in people who have kidney disease or liver disease. It is contraindicated in patients with congestive heart failure, and because we couldn't push fluids on them. And then seizure patients should not take this because of the myelosuppression, and then we would not give it to pregnant or lactating women. Some common drugs are Tamiflu and Relenza or Rapivap. Some common chronic hepatitis medications that are antivirals might be Adedavir, interferon, lamivudine, and entecavir. Notice the vir at the ends of many of these is a non-HIV antiviral. We want to teach the side effects and make sure that the patient takes the full cycle. So, important things to know on that one is that if someone has the flu and is asking about Tamiflu as an option and they've had the flu for 4 days, then it's not going to work for them. And they will need to, if they had it, symptoms 24 hours and they get it prescribed, we want to tell them to increase fluids and to get started on it within 48 hours of symptoms. And then it's not going to cure them, but it's going to make it less horrible. Antivirals for HIV is, there's many drugs here, so I really am just going to talk a little bit about this. HIV and AIDS is still not considered curable. There are 5 different classes of antiviral drugs. No, you do not have to remember all of them. Reverse transcriptase inhibitors, protease inhibitors, fusion inhibitors, entry inhibitor, CCR5 co-receptor antagonist is the newest class, which has shown a lot of promise with our HIV patients, and then HIV integrase strand transfer inhibitors. There are also subclasses, and I've listed those here for you. The most effective treatment to date is HAART, which is highly active antiretroviral therapy. It's usually at least 3 medications. They're always on combination medications. The most commonly recommended drug combo includes 2 or 3 NRTISs, 2 NRTISs plus 1 or 2 or more protease inhibitors, or an NRTI plus an MNRTI with 1 or 2 protease inhibitors. So basically you need to know combo drugs is what's effective here. Despite the effectiveness of HAART, prescribers may need to alter a patient's drug regimen based on drug intolerance or drug resistance, and they're going to be watching their T-cell count. Okay? Common drugs that you might hear about in the HIV combos are TDF, FTC, 3TC, EFV. Notice we almost use chemical names with the antiviral HIV drugs. So tenofovir does have that vir suffix, but basically you need to know that they need to take these doses consistently. Like, this is life to them. In order to prevent AIDS, they need to take these consistently at the same time every day, and they need to know about the common side effects. And let me see if there was anything else that I thought was really important about that. The big thing that with antivirals, on the previous slide I told you that Tamiflu needs to be started within 48 hours. Retrovir, which is also a flu one, can be dose limiting because of the bone marrow suppression types of side effects. So if they had a lot of bruising or bleeding, that would be a dose limiting effect, and we would stop it. And anytime that someone has kidney side effects, we need to make sure that we increase lots of fluids to prevent any kind of crystalluria or stones. And with your antivirals for HIV, they're going to have blood work done frequently to be able to T cell counts to make sure that they're on the correct regimen to prevent the HIV virus from moving into AIDS. This is the most common list of antivirals. This is all of them together, but acyclovir or Zovirax is most commonly used for herpes zoster or for the shingles. And ribavirin or Virazole is a common antiviral drug. Tamiflu, Relenza, and Rapivap. Retrovir is, notice the virs at the ends of the antivirals. The HIV ones are the tenofovir, lamivudine, which can also be used for hepatitis, FTC, and EFV. Hepatitis, lamivudine, adafovir, Tyzica, entecavir, interferon alpha-2b or intron A. Those are all hepatitis antivirals. So definitely be familiar with Zovirax being used for herpes zoster, or for Valtrax would be also acyclovir. They're both acyclovir. Valtrax, you've seen commercials for genital herpes. So those are the most common ones to be familiar with. Alright, so the Munchkin mare has shingles. The Munchkin mare 79, seen in the clinic for painful rash that runs into a half circle along the rib line. The rash is composed of raised fluid-filled lesions. Usually these, the shingles follows the dermatome patterns. It can be very, very painful because it's like the nerve endings are on fire. The patient describes the pain as the most severe pain he has ever experienced in his life. The physician makes a diagnosis of shingles and gives the patient a prescription for acyclovir or Zovirax. The patient has some questions for the nurse regarding the disease. Now what, so what? The patient asks the nurse why she has developed shingles. How will the nurse respond? I should have had he there. The nurse will inform the patient that shingles is caused by the virus herpes zoster, and when someone has chicken pox or varicella zoster, as a child, that virus lies dormant in the nerves, and then it's reactivated decades later and can cause a painful rash referred to as shingles. We think that this is often brought about by increased stress levels. Nurses need to be familiar with the different types of herpes viruses and understand the manifestations. They can be a little bit confusing, so make sure to provide the best patient teaching possible. The mare asks what kinds of side effects he can expect. How will the nurse respond? The nurse will tell the mare that some really common side effects are nausea, diarrhea, and headache. If we were giving this IV, we would be concerned that it could cause kidney damage. So we would want to definitely give it over no less than an hour, and we would want to make sure that we increase fluids to prevent any kind of crystalluria or stones. The patient returns to the clinic 4 weeks later stating that he still has severe pain where the blisters once were. How would the nurse instruct the patient in regards to the reason for this pain? Well, as we talked, this follows nerve endings, and so we call this post-therapeutic neuralgia. So it's long-term nerve pain. This happens in about half of the older adults who get shingles. The provider can prescribe pain medication to help with the symptoms, but it remains in half of those after the shingles outbreak. Early administration within 72 hours of symptoms of acyclovir may speed the recovery, but this effect is usually not dramatic. So just like we've talked about with Tamiflu, the same thing. We've got the quicker you start it, it's going to lessen the strength of the virus because it works on the replication inside the cells, but it's not going to cure it. The healthcare provider can prescribe opioids for pain control, and there's also an acyclovir cream that we can put on the blisters too. So, a little bit about fungus. A variety of fungi can cause infections or mycoses. That's kind of the term for fungus amongus. Infections range in severity from mild to annoying, so athlete's foot's an example, or systematic mycosis that can occur in the lungs, and that can be life-threatening, or in the heart. Fungi really can be ingested orally, can grow on or in the skin, the hair, the nails. People have had toe fungus and toenail fungus. If the fungal spores are airborne, they can be inhaled. The most severe systematic fungal infection generally affects people whose host immune defenses are compromised. So somebody who has an autoimmune disease could get a fungal infection that could be life-threatening. So the antifungals end with azole, and that's the suffix. Antifungals are a small group of drugs, yay. There are few because the fungi that cause these infections are difficult to kill, and the research into new and improved drugs is very slow. The remaining drugs include 4 classes: Paulines, which includes your amphotericin B and nystatin. In this particular case, I want you to be familiar with amphotericin B and nystatin, and we'll talk a little bit about that. The imidazole, which is ketoconazole, triazoles or fluconazole, and you can see all of these end in azole, and except the 4th class of the echinocanids, the capsofungin, mycofungin, and anidulafungin. Yeah, but it does end in fungin, so that at least helps with those. I am most familiar with the amphotericin B, nystatin, and ketoconazole, and even fluconazole. Major side effects caused by antifungal drugs. The most common one that we're going to talk about that has the most, the severe side effects are amphotericin B. Drug interactions and liver dysfunction are primary concerns for the other antifungal drugs. We actually use pre-medications to treat possible side effects that can be really awful from amphotericin B. Amphotericin B, or fungazone, is the drug of choice for systematic mycosis. So if somebody has a fungus growing in their lungs or in their heart, then we might use amphotericin B. Almost all patients given the drug IV get fever, chills, hypotension, tachycardia, malaise, muscle and joint pain, anorexia, nausea, vomiting, and headache. So, before we ever give that drug, you're going to treat them with an antipyretic for fever, so they're going to get acetaminophen. This is a protocol. They're going to get an antihistamine, either likely going to be a diphenhydramine or Benadryl, and then they're going to get an antiemetic like Zofran to help with vomiting, to decrease the severity of these side effects. There is also some other common side effects and nursing considerations that I would have you look at in your text, but what I would say is really important to know is that with amphotericin B, in order to find out just what kind of side effects that they might have, or to make sure that they don't have an anaphylactic reaction, we start by doing a test dose. And I talked about this in class, where we either might give them a little bit of IV, or we might do a little bit of a skin test on them to see how they react. Then Before we administer it fully, they're going to get an antipyretic, an antihistamine, and an antiemetic. Nystatin is given for yeast. So back when we were talking about superinfection, if somebody were to get yeast in their mouth or candida, then we might give them nystatin, and we would teach them to swish and swallow. There's also nystatin creams and nystatin powders for yeast on the skin. If a person did get anaphylaxis from any kind of a drug, we would need to stop the IV immediately, and then next week we'll talk about drugs that can help with that, but I bet you've heard of epinephrine. So that would be what we would do with this. Amphotericin is only used for systematic fungus, and it is a dangerous drug. I just wanted to provide you a list of the most common antifungals that you might come across. Clotrimazole, iconazole, ketoconazole or Kenalog, miconazole, teoconazole, so see how they all end in zole, terbinafine, that one does not end in zole, nystatin or mycostatin would be another name. Fluconazole is also known as diflucan, and that's a pill if somebody has a severe yeast reaction or candida, that we might also treat it systemically with the pill. And then the amphotericin B is the dangerous antifungal. Alright, so one of the Munchkin ballerinas brings her 3-month-old son to the pediatrician's office today. The baby's fretful, crying, and inconsolable. The mom tells the nurse that the baby has a significant diaper rash. Upon examination, the buttocks and the entire genital area are red, and there are satellite lesions, so meaning little lesions all over the place. The nurse suspects the rash to be a candidal infection and expects the physician to order an antifungal cream, such as nystatin. Or in my case, I prefer that they order the powders as a woundostomy nurse, because especially with patients who might get yeast in their folds, you have wet skin on wet skin, it's dry, it's moist, so you put moist cream on it, and that doesn't work as well as maybe the powder does. But we'll go ahead with the cream because this is the baby and it's on. Now what, so what? What instructions will the nurse give the mom about using nystatin and applying it? We want to apply a thin layer 2 to 3 times a day. It should be applied sparingly. It's not one of these things that more is better, and the same goes with the powder. And even with the powder, we need to brush off excess. It doesn't need to be applied with each diaper change. Inappropriate application can actually delay healing, and it gets expensive. Mom asks when she should see improvement in her son's rash. How will the nurse respond? The nurse will respond that we should usually see some kind of improvement within the first 24 hours. What additional patient teaching will the nurse provide? Apply the cream 2 to 3 times a day until the rash is gone. They can place a barrier ointment over the nystatin if they choose to do so. So like a type of for a barrier ointment for urine, so like Desonex or Super Duper Diaper cream. That'll be fine. The only recognized side effect can be local irritation, and if this occurs, then we need to have the patient contact the physician immediately because they're having an allergy. Compliance with any medication treatment is essential to success, and if they stop treatment too early, the rash could just reappear and be more difficult to treat because of the way that the virus is spread. Or the funguses. Alright, so we have an issue with the Tin Man, and he has had a new heart placed and it's infected. He has developed a systematic fungal infection causing what's known as bacterial endocarditis. So that is around the lining of the heart and the endocardium, and it is bad news. The fungal infection is unresolved after receiving fluconazole or diflucan, so now we have to move up to that ugly old amphotericin B. Now what, so what? physician feels that it's time that we move on up to the big guns and give amphotericin B. So what is the concern with side effects of amphotericin B? We know that it can cause severe liver damage, and then the patient's going to get chills, fever, they can have some allergy to this, and we have got to pre-medicate. It's critical that we treat because of this being endocarditis, but if we have toxicity, then we could have to stop or slow down the drug despite life-threatening systematic mycosis. So we're going to look at renal function closely because it works on the kidneys and can cause problems with the liver too. But the side effects are often GI, nausea, vomiting. Rigors happens with fever, and like the patient tenses up, and it can be really painful. Fever, blood pressure changes like hypotension usually, and then hypoxia or lack of oxygen. The long-term adverse effect is absolutely nephrotoxicity, or this could kill the kidneys, especially for those who've taken another antifungal first, as was in this case. So we're placing this patient at risk for long-term kidney problems. But if we have endocarditis, this is a balancing act, and we've got to treat the endocarditis. What nursing priorities would be addressed before administering it? Well, we are definitely going to do a skin test first to see what's going to happen, and then we're going to pre-medicate with antiemetics, antihistamines, and antipyretics, and even corticosteroids, and then we're going to administer very slowly, and this patient's likely going to be in the ICU. Because of the well-known side effects of toxicity, amphotericin B is not given until the patient's been pre-medicated to prevent and minimize reactions. We also oftentimes do a little bit of a predetermined test to find out how bad the reaction's going to be. You know, we might even have epinephrine at the bedside. The reactions can also be decreased by using, by giving the drug over a longer infusion time. And despite all of these side effects, we're really trying to medicate for the side effects so that we can give the big ugly mean drug, because it will, with any luck, save his life. Okay, so just as a little summary, I want you to review antibiotic peak and troughs. We talked a lot today about antibiotic misuse, or how we have really kind of come into our own on antibiotic resistance. A lot of these drugs cause kidney problems, and so we need to watch VUNs and creatinins and encourage fluids. No drugs classes that cause photosensitivity, such as sulfonamides and tetracyclines specifically. I want you to make sure you know about superinfection, and an example would be C. diff, and how we treat that with Flagyl, and how we can prevent that and do some patient teaching with probiotics and yogurt with live cultures, and acidophilus are examples of trying to get that normal flora in the skin. Something unique to tetracycline was that we don't give it to kids less than 8 or pregnant women because of teeth. Sulfonamides are one of the drugs that cause the crystal urea, so if you have any drugs like that, increasing fluids will help prevent that. Many of these drugs with the antibiotics could lead to kidney problems. Know about peak and trough with vancomycin, and if it is, if we've got a trough which is done before the medication is administered and it's critically high, then we're going to hold the drug and call the doctor for orders before we give it and kill their kidneys more. With the aminoglycosides, some symptoms of kidney issues might be ototoxicity, so if they start having ringing in the ears, tinnitus, vertigo, things like that, then we might be hip to the fact that there might be something going on with the kidneys. With fluoroquinolones, tendon rupture was a big black box warning on that one, and so muscle diseases would be a contraindication in that drug. Another thing that can increase a person's risk for tendon rupture with fluoroquinolones is use of corticosteroids. Tamiflu needs to be started within 48 hours of symptoms. With Redovir, a dose-limiting effect could be bone marrow suppression. Acyclovir is for herpes zoster or for genital herpes. And if we give it IV, it needs to be infused at least over an hour to decrease kidney damage. And I've already talked about how increasing fluids with a lot of these will prevent crystalluria or stones. You need to know about prophylactic drug therapy versus empiric versus definitive. So with prophylactic, we give that preventatively. Empiric is a educated guess, and then definitive is based on cultures. So you definitely got to have cultures before, you got to take the cultures before we start antibiotics. Antiseptics cut down on bacterial growth on living tissue, whereas disinfectants destroy, or they're bactericidal, on non-living surfaces. So antiseptics are more bacteriostatic, so knowing the difference between those two as well. And with your actions, just know if it's bactericidal or bacteriostatic on your antibiotics. Don't worry about the very, very specifics on those. With penicillin, cephalosporins, there could be cross-sensitivity, so we discussed that if somebody's allergic to one, they could be allergic to the other, so we've got to watch them. Tetracycline requires sun prevention or sunscreen kind of teaching. If somebody has anaphylaxis, stop the antibiotic first. And you should get cultures before administering antibiotics. If somebody has severe diarrhea after antibiotic use, they might have C. diff and need to be tested for it, and then the treatment of choice is Flagyl. And if we want to know if somebody's doing well on their antibiotic therapy and we see a decrease in white blood cell count, that would be a good clue that it's working. With amphotericin B, we need to pre-medicate with antipyretics, antihistamines, corticosteroids, and am I forgetting anything on that? So fever, allergy, pain. So I think that's it. We're going to give those a lot of fluids and give it slow, and they'll probably be in the ICU. With nystatin, if we give the oral form, they need to swish and swallow. And I believe that that's kind of a big thing. Most of the antibiotics had the nausea, vomiting, diarrhea, GI symptoms, but focus on what makes certain ones unique. And I believe that that will do it for today.